He said it is prime time versus if you want a juicy thing, you get late evening slots, so I finally settled for this. So what I'll discuss here is what is an audit, what are the types of audit, is audit same as research, what can be audited in the ICU, can we start auditing right away in the ICU, and how to conduct effective audit in the ICU. Audit can be defined in various ways. I have chosen two simple definitions just to highlight the point. It can be systematic critical analysis of the quality of medical care, including the procedures used for diagnosis and treatment, the use of resources, the outcome, and quality of life for the patient. So everything is for the patient. That's very important here. Another definition is audit is sharing by a group of peers of information gained from personal experience and or medical records in order to assess the care provided to their patients, to improve their learning and to contribute to medical knowledge. So we gain significantly when we are doing these audits. Why is clinical audit so important? Well, there are many aspects to it. It identifies and promotes good practice. It can lead to improvement in service delivery and outcomes. It can also provide the information that we need to show to our patients, to our healthcare managers, to our management, that we are cost effective, we are service effective. It provides opportunities for training and education. It ensures better use of resources and increased efficiency. And it can improve relationship between the various groups of healthcare givers and the managers. So to put it very simply, if you are planning an audit, you have to develop and establish standards of care in your unit. Then you also have to develop a process of continuous evaluation to check whether the protocols are followed and also to update them based on whatever audit reports you get. Coming to the areas that we can audit, these are structure, process, and outcome. As we know, structure is the availability and organization of resources. We can look at various issues, doctor-patient ratios, multidisciplinary meetings, availability of quality equipment, so on and so forth. Processes are one of the most important issues in critical care. Large number of processes that are related to patient care utilization, resource utilization can be looked at. We can look at expert individual patient care, admission discharge issues, equipment maintenance. We can initiate a process either by using a stepwise approach and using troubleshooting, or by systematically analyzing all processes, which is cumbersome, but gives you very good information, and you can also develop your standards of care. Some of the examples of structure measures are, you can look at size of the ICU, type and amount of technology, number and roles responsibility of the staff, the workload case mix, level of supervision. Then you can measure the whole lot of these processes to look at whether you are doing good as per the standards. So a lot of processes can be looked at. Outcome, again the effect of structure and process on the well-being of the patient is what we mean by outcome. Whole lot of issues, you can look at the mortality rate, the severity adjusted SMR, ALOS for the severity of illness and type of disease, health-related quality of life, unplanned readmissions, a lot of other things, infection rate, ventilator-associated pneumonia, cost per surviving patient. Is audit same as research? Well, there are clear-cut differences between audit. It's not same as research. Research, the aim is to establish what is best practice. In audit, we are evaluating how close our practice is to the best practice. Research is designed so that it can be replicated in a similar way, whereas clinical audit can be specific to your own institution. It cannot be replicated in another institution where the situation will be different. Research is aimed to generate new knowledge, increase the sum of knowledge, whereas clinical audits are meant to improve the services. Another important difference is clinical audits do not involve randomization of the patient or a placebo treatment or starting any new treatment. The problem solving approach technique is identification of a problem, precise definition of the problem. You have to define what you are looking at, what is the problem. Then you have to look at all possible causes for that problem. Try to analyze do a root cause analysis. Also develop and implement a possible solution. Then monitor the effectiveness of that solution, providing a feedback so that the system improves. There could be various kinds of audits. Most common audit that is done by in my ICU by the administrators is the stock audit. There could be various reactions to audit. I know my nurses are, the in charge is very worried whenever there is a stock audit due. There could be enthusiasm, especially in the beginners. Some of us would be quite cynical. Some will doubt the usefulness of audit, and some are quite exhausted when the audit is done, because it's a time-consuming, labor-intensive process. Can we audit right away? Can we start doing it just from next day? Well, we need to have a robust data collection program in place, like the infection control data, WAP, CRBSI. We need to know our infection rate. We need to look at all this data. So we need to be prepared. If all these things are in place, then probably you can look at improving the system by continuous audit. So this is something that we do in my hospital. You can see that all the various rates are there. And we are also looking at the other admission and outcome data. This is some additional information that we look at compared with the previous month. So once we have this kind of an infrastructure, the data collection program ready, we can look at the trends. We can look at the major deviation from set standards that need to be analyzed or audited. So we have the audit cycle which can be defined, problem objective identified, criteria agreed or standard set, like you can define for your unit what would be the CRBSI rate. In my unit we accept less than 5%, WAP less than 10%. And then you can re-audit after you have put whatever improvement strategies are there. So audit is a very, very important part of the clinical governance. As you can see here, it overlaps with almost all aspects of clinical governance. Various things can be audited, like you can audit things regarding the CVC catheter. In my unit, I do a death audit for all the patients that die. We look at the ER issues, the ward processes, ICU process. We also look at the transportation because it's very organized, protocolized. We look at nursing issues, physician issues. We involve one administrator, one nurse in charge, one nurse educator, one independent clinician. When we are analyzing, the death audit findings are then sent to the audit committee. Then subsequently they will call based on the relevant findings, the stakeholders, and take a corrective action. The other audit that we are doing is the code blue audit or a CPR response audit. Again, we have a set protocol and we analyze this data every 15 days. There is a code blue audit committee and CPR committee. Coming to another important issue, we just did this audit a few days back. It was an outbreak audit. We have in our hospital an effective hand hygiene program in place. We use chlorhexidine alcohol hand rub. They are placed everywhere near the bedside at common points, entry points. We have isolation practices in place, and there's a daily round by infection control nurse. We have a nurse educator in place, passive surveillance of hand hygiene in place. WAP bundles are practiced, recorded, any non-compliance is recorded. We have suction protocols in place. We do not go for open suction, and we have a very active clinical biology, clinical microbiology. So when we found that our WAP rate, if you see here, for the month of November and December, we had 0 WAP rate. We had significantly high in December last year, but that was because the staff allocation was for 50% occupancy. The resident staff was also allocated for the 50% occupancy. For 25% of ventilation were assumed to be on ventilator, whereas the actual occupancy in December 2010 was 90%. The ventilated patients were 70%. So we had, system was overwhelmed. nurse-patient ratio was reduced to 1:3. So a whole lot of problem we found, but the system had improved. If you see, we were doing quite good, close to our target of bringing it to less than 10, and we achieved that here 3 months. We had 0 here previous 2 months, but in January it again shot up. So we wanted to look at this, why this is increased so much. Well, there could be an argument that we had sick patients. Well, ICU is meant to look after sick and sicker patients, so that cannot be an argument. So this was an issue that we decided to audit. Was it due to shortage of nurses, non-compliance of lab bundles, non-compliance with hand hygiene, deviation from standard suction practices? These were some of the things we identified. The standards used in the ICU was that for isolation and ventilator patients, the nurse allocation would be 1:1. For all others, it will be 1:2. And for hand hygiene, the standards were 100% compliance. For suction also, it was 100% compliance. We found that nursing education program was doing very well. There was 97% attendance. Hand hygiene, only 2 brief 2-hour surveys were done, so because of the manpower constraints, but it recorded 85% compliance. Suction practice, we couldn't really evaluate. Random interviews by the nurse educators showed that 90% could describe the correct suction technique. Lab bundles compliance reporting, we found that there was a bias because of the increased workload. It was left to the staff nurses to fill up the compliance with the monkey forms. So we identified probably the nursing staff strength and allocation could be a major issue here. And look at what we found. The number of patients on invasive ventilation per day was between 8 and 9. We had 2 to 2.3 patients in the isolation room. So rest of the patients were non-ventilated. They could have been on BiPAP or otherwise on oxygen therapy. So the nurses that we require based on the presumption that I described just now was about 14 per day per shift, day and night shift. The nurses allocated we found were 1 nurse less per shift. And another important factor was, although we had 1 nurse less, but again in this less number of nurses allocated, we had a lot of nurses who came from outside. They were non-medical ICU nurses. 18% during daytime, 12% during nighttime were substituted from outside. So we had, and out of these, 18%, 57% were from wards. During nighttime, as high as 70% came from the wards, those who were not exposed to ICU. Limited number came from other ICUs, but these were like the CT-based ICU, ICCU. So
last 1 minute.
Yeah, we identified that this was a major source of increase in the WAP. This report has been sent to the nursing administration and the medical administration for some action. So, ladies and gentlemen, an effective audit is one which is an educational activity, which promotes understanding, which is resource effective, which can raise the standards, which can promote change, and which also is a source of information, which is led by peer group, which involves patients, because what we want to improve is patient safety. I'll repeat again here that the number of the medical industry is expanding very fast. The number of hospitals are increasing. We have international tourism coming up in a big way. By 2013, it's going to exceed $3 billion in terms of revenue. So we need to be very, very quality conscious here. Thank you.